This meeting is being recorded.
So what we want to do is talk about three cases today that, good morning, Dr. Pricey. Hope all's well for you back there.
It is, thank you.
So we got three cases, all of which have come out of our, of course, our body of work at DOD, and two of them were calls I got from providers, and one was a case I saw that I think really indicate, demonstrate interesting aspects of work comp and some of the dilemmas we face. As we recall, work comp is a different beast than group health, and in some ways, in fact, in many ways, group health is a lot simpler. You just treat what's in front of you. But with work comp, we have to be distinguishing, as just briefly discussed with the cholinesterase case with Millie, issues of causation, but then also when there are consecutive injuries of the same body part or consecutive injuries of different body parts that overlap, how do we handle some of those? And so two of these cases will address that issue. And then a third has to do with closing a claim, which continues, I think, to be a challenge in many cases for us. So the issue here was whether to create a PR2 or PR4 for a case at the conclusion of care. And are you seeing my screens okay? I'm assuming.
Yes.
So why this case? Well, the question is, how do you decide whether to submit a PR2 or a PR4 when a patient's reached MMI and had a pre-existing problem of the same body part? And this arose a couple of months ago. Here's the story. The patient's a 32-year-old male who worked during the school year at a local university in a maintenance sort of role for the prior 4 years. So a young guy, he had a history of job-related chronic back pain for more than 10 years and still had an open claim for an aggravation 3 years prior to the onset of the current condition, the current injury. So prior claim, unknown if it was settled or whatever, and then an open claim for an aggravation. Then in August of last year, 2021, he had an increase in back pain while working, third event. Pain was felt primarily in the left low back, about 3 out of 10 at rest, increasing to 5 out of 10 with more strenuous activities. Twisting or repeated waist bending, as well as strenuous activities, all made the pain worse. He was assigned light work with limited lifting and a 4-hour workday. His back pain by September of last year is diminishing somewhat, but really not going away. He expressed a desire to return to full-time work, but on a light duty basis. And that may well have been just the fact that that his salary was probably being adversely affected by this. So in November of last year, physical therapy was authorized and was to be scheduled. He was taking ibuprofen and was prescribed Flexeril, but never picked up the Flexeril. So he was just taking ibuprofen. Later in November last year, he had physical therapy. He was pain-free for 2 weeks and felt he didn't need any more physical therapy. MRI had been requested and performed of the LS spine, showed a mild disc bulge at L5-S1 with some spinal stenosis. He was doing home exercise program and yoga twice daily. So MRI showed a non-surgical condition. And then by the end of the month, he had no back symptoms. There was no pain or radiculopathy. He was felt to be maximally medically improved. However, there was a concern because of his history, he would perhaps need future medical care for anticipated flare-ups. So the question that came to me was then by one of the providers, do we do a PR2 or a PR4 on this? Does anybody have an opinion on that based upon this history? What would you be inclined to do at this point? Patient wants future medical care, but he's symptom-free at this point. What would you do if you were confronted with this situation, or this is where you got to. Anybody care to venture a guess? You'll earn a penny if you comment.
Steve,
Yes.
What-
Oh,
Mickey?
was this most recent claim placed on his present employer, or was it does it go back to his previous injury and a previous situation?
Yeah, that's a great question, Mickey, of course, is who's been the employer for these three events? In this case, it was believed to be the employer, the same employer for all three. A question, of course, would also be, did the employer change carriers during that time? But it's believed that same employer, same carrier throughout that period.
In that respect, I would probably do a PR4 with Future Medical,
Okay, and what would be the basis for making that decision?
because he has had a pattern of exacerbation, it sounds like, over the years, and one can anticipate that that's most likely going to happen again.
Right, that's fair enough. Here would be the thing, and I think that's a great point, making that's actually really the key issue. What the questions in my mind would be, was this current injury an aggravation or exacerbation? You remember, aggravation is when there's a pre-existing problem and a patient's condition is made materially worse, then that constitutes an aggravation. If it just seems to be kind of the waxing and waning, predictable waxing and waning of that problem, then it's considered an exacerbation. So it looks like it was considered to be an aggravation, that there was a bona fide change, and we'll come to some of the criteria for that in a moment. And so then the question is, does he need a PR2 or PR4? And in this case, it sounds like he had that second injury, the claim was not closed. And then he's got this third event. Are we talking about closing two claims or one claim? Are we talking about, are we really managing two injuries or one injury? And then is there a basis for future medical care? So if we look at our graph, now I've drawn in somewhat inelegantly a red line that indicates in my mind what's going on here. You'll recall that with the A graph, it's, let's see here. There we go. Yeah, in this case, with the A graph, that's most injuries start off with time 0 with no symptoms or signs and then resolves. B, of course, is when a chronic problem develops and persists. And then the C graph is when there's an aggravation on top of a pre-existing injury, B. And then seemingly the red line was this fellow's current condition, which is another event that's occurred, but now has gone back to baseline if he's truly symptom-free. So if we try and visualize it, this is what I think the situation is, what represents the situation. So what I recommended was, addressing these questions. First thing, it'd be interesting to know if there was a claim from the 10-year history of back pain or not so, and who was the employer? That's what we asked before. And was it settled in some way? Was it settled prior to the aggravation of 3 years previously? So was that an unclosed claim, or was it an injury that actually was not managed as an injury? Was it not reported? It was just, it occurred and not treated as a work comp claim. And then he had an event 3 years previously. So was there something that was closed on the first claim and then on the 3-year claim seemingly still open? And if either of those two were settled previously, or the first one, what was the patient's condition? Was there whole person impairment? And was there a provision for future medical care after that first event? And then was the 3-year aggravation still open? And if so, when is it expected to close and on what basis? And that is with the difference, remember, we've talked about before, how you close a claim, either by compromise and release, CNR, where there's money paid to the patient and then the insurance company's out of the picture, or was it closed by stipulation with future medical care? Because one of the issues on these always is when there's a new problem, is it really just an exacerbation of a previous problem, or is it a brand new problem? So it's hard to know really how to manage this accurately without knowing this information. My sense of this is that we probably would close this on the basis of PR2 for the following reason, although I agree with what Nikki's thinking is. To provide for future medical care, there needs to be residual impairment of some sort. So if there's going to be a provision for future medical care, what they're doing is providing for future treatment for whatever the impairment is. And the impairment can be mental or it can be physical. If there's no impairment, then generally, there's no basis for future medical care. There's no provision for something to be treated. There does not need to be, you can have impairment. There does not need to be permanent disability to have future medical care. There are a number of cases that we close with some sort of impairment, but the employee is able to go back to their regular job. So there isn't disability, but there's a persistent problem. There may be back pain that continues. There may be some sort of mental symptoms that persist, any number of impairments that can occur on the job, carpal tunnel syndrome, symptoms persist. There can be provision for future medical care, but future medical care is directed towards a persistent impairment. And in a case like this, where the patient says he's back to a pain-free state, there would presumably be no impairment. Now, one hooker would be if the MRI had shown significant disc problems, something that might need surgery, the impairment need not be visible. It may not produce symptoms, but if we have the diagnosis of significant disc degeneration, nerve root impingement, or something that's demonstrable on MRI, that constitutes an impairment. And so there could be future medical care directed towards treating that condition. But if the patient's symptom-free, has no problems, and any changes on MRI are minimal or on X-ray, then there really isn't a basis for a PR4, and one would do a PR2. So in reporting, in closing the claim, PR2, if there's no impairment, well, they say, or disability, there doesn't need to be disability. If there's no impairment, and a PR4, if there is impairment, and then you can recommend for a provision for future medical care. Now, I get that the patient's concerned about the future, and I've had this a number of times come up, and what I tell folks is, in the first year, a claim can be reasonably easily reopened. And what the patient does is talks to the employer and then goes to the carrier and says, you know, my problem never really completely went away, something along that line, and they want to reopen the claim. And most of the time that can be done without too much of a problem. The other situation then is if the person has a bona fide new injury, something else happens that constitutes a new problem, then that claim will be opened and treatment starts anew with that problem. And then that becomes, in this case, a fourth injury. So the employee is really pretty well protected going forward, as long as if any symptoms show up in the first year. And I've actually had some employers and carriers, incredibly, that have been willing to reopen claims several years later, which is longer than what's usually accepted. But nevertheless, employees by and large can be taken care of for this if they have a recurrence of symptoms. And so I just tell them, talk to your employer, report it, that you're having the same problem again, and then talk to your carrier. And most of the time, without too much problem, they'll reopen the claim. So
Dr.
suggesting that. Yeah, Danny.
Would that be even if they have a new employer, could they still open up a claim from the previous employer as long as the insurance is the same?
Great question. What they would do, now that does get trickier. And so they would go back to the prior carrier. And at that point, they wouldn't need to call the employer because the relationship is with the carrier. So they would go back to the carrier and say, you know, my problems recurred. Now, what always happens in this sort of situation is there becomes a little bit of wrangling between the carrier, the older carrier and the new carrier. The old carrier is inclined to say almost invariably, well, this is really a new problem. Talk to your new work comp carrier. And the old carrier is always inclined to say, well, this is really a continuation of a pre-existing problem. Talk to your prior carrier. Now, the only time that doesn't work is, or one of the times, the main time, is if the claim is settled with a CNR, compromise and release. And so the employee has been paid money and does not have access to the carrier from the prior injury. So that's one reason it's always interesting to find out and useful how these claims got solved. So, but that's a problem. Another twist that can occur, not real commonly, but periodically, is that same employer, new work comp carrier. Because these employers change carriers from time to time. Most don't change often, but some will change, you know, every couple of years. And in a situation like that, then the same argument goes on between carriers, but the employer is the same. So that gets to be a little tricky, but but if the employee had provision for future medical care from the prior carrier, the issue still can pop up where the old carrier will say, well, you've got future medical care, but this really looks like a new problem. You need to speak to your new carrier. So that argument occurs. And what often happens in that situation is the carriers will agree to a QME and let the QME decide if this is really a new injury or an old injury. I think here's where we fit into this at the start. And this is one of the reasons why it's so important to ask about any previous problems when we confront an injury, and just gather as much information as you can on the previous injuries, because it'll pay some dividends at the end when it comes trying to decide, you know, if this sort of issue arises, how you're going to resolve this. So if you can ask about any prior injuries, ask how they got settled. Sometimes, in fact, some employees don't have a clue. They got a check and they don't know what's going on. But if the employee knows, if you can get a hold of a prior PR4 that was the basis for a settlement, if one existed, I don't usually try for that until the end of the claim when there gets to be a real issue about this. But I would at least document prior injuries and what the outcome was. Was the person completely resolved? Were they not completely resolved? You know, was there some sort of provision for future care? Just document that, because it'll make decision making at the end easier. And one of the things you want to do is continue to try and visualize these on this graph. It's really fairly helpful to figure out where you are and where you're going, how you're going to manage things. If you have some sort of mental sense of what the current condition is and what the prior conditions were. So I would just, it's a vote for trying to gather as much information as you can. But that's a great question, Danny.
I had a question. I'm sorry if
Nope.
I missed this, but I thought we had to file a PR4 to close the case if things were done, whether they needed future medical care or not.
No, PR4 is when there's impairment, and actually there needn't even be need for future medical care. In some cases, following surgery, even with complete recovery, the carrier wants a PR4. But normally the PR2 is a garden variety, just a garden variety case where the patient's back to pre-injury status, no residuals, no impairment, no physical or mental abnormality, no significant radiographic abnormality, they've recovered and they're as they were before, what's referred to as being back to pre-injury status. If that's not the case, then it calls for a PR4.
Okay, I've been doing that wrong. Thank you.
And Amanda, when you have these, if you have, there'll be some that'll come up that are gray. And if you have a question, just give me a call or give Dr. Pricey a call, but always happy
Well,
to
since
talk about.
Epic,
I'm sorry.
since Epic, I thought there was an option when you discharge, it'll ask for permanent disability or not.
Right.
And I had assumed that was the PR4. So I haven't actually been inputting PR4. So, maybe I was just confused with what that actually looked like. I thought when you're closing it, it's still a PR4. You're just specifying whether there's permanent disability or not. And then the other question I had was,
I'm sorry, let me address that quickly.
Okay.
When you're doing that, that final, what's it called? I forgot the name of that dialogue, but in any event, at the bottom where it says, there's a choice that says discharge, and you have two options there. One is for a PR2, or it says no permanent disability, no permanent impairment. And then right below that is PR4. So that's the last choice you have on that dialogue. It's where you're putting down it's right below treatment plan.
Okay.
And then you can continue further to PR4 if PR4 is needed. It's there for you to click on and fill out. But if the patient's back to pre-injury status, no residual impairment, no problems, back to how they were before they were injured, then you just you click on the box that is for a PR2 and nothing more.
And does it send automatically with Epic?
No, actually, another really good question. What you need to do, correct me if I'm wrong on this, Dr. Pricey, but we type in PR2 down under the orders, and then that will be generated. And there are several choices for a PR2. We send out PR2s for various reasons. One is every 6 weeks, we're supposed to theoretically. If there's a change in the patient's condition, if there's a change in the patient's work status, something materially different happens. And one of those is other, which is when we're discharging a person with a PR2, we click that, we make that choice. It's the last one on the PR2 choice. And then I usually type in down, I've got a little macro I put in and type in under comments that the patient's return to pre-injury status, no residuals, can be discharged, no further care, that sort of thing. And then in our office, that our work comp schedulers do it. I don't know who it does it in the other offices, but that will generate the PR2, but it doesn't, unless Dr. Pricey, if I'm wrong, it doesn't happen absent taking that step. Actually, he's probably gone. He's probably at the wedding, but
You're correct, Dr. Schumann. And it will drop into the work comp coordinator's work queue to generate and send out.
okay. So do that. If the person's back to pre-injury status, and this is going to be probably 80% of the people we see or more, is click on that box under the next choice below treatment plan. Take the first choice, which is no impairment, and you don't need to do anything. And then you put in the order for the PR2.
Okay, great. Thank you.
Any other questions?
Well, I also don't know if I missed this, but when the guy came in to begin with, if this was part of it, I heard you mention that at the end you were going to call the adjuster to find out, if he had a previous claim that had future medical care. I thought that had to be done at the beginning, and kind of when he comes into us, if it was part of a previous case, they have to reopen that claim instead of starting a new one.
Well, that's the ideal thing to do, is to talk to the adjuster and see what the status of the claim is. One of the things that we make a presumption, the employer will send the patient in with their employer's first report, and they'll have on that sheet, one of the sheets we get, excuse me, has a date of injury. And if they're aware that there was a previous problem and thought to be related to that, they'll write sometimes that older work injury date, date of injury from the prior claim, prior injury. Otherwise, what they'll do is if it's believed, if it's what the presumption on their part is that this is a new injury, they'll write the new injury date there. And so that's the first piece of information. It is really useful if we're willing and able to get a hold of the adjuster. And the problem, of course, is you want to call the adjuster when we're seeing the patient for the first time, but there's no claim. And when I've tried to do that in the past, to open, as we've talked about before, to open a claim, the adjuster needs to get the employer's first report and the doctor's first report. Otherwise, no claim number is assigned. So occasionally, with a few of the adjusters we know well, like for the hospital, for some of the other employers that adjusters we've worked with for a long time, they'll give us some guidance on what they think is going to be the situation based upon what we tell them. But the vast majority of adjusters say, even actually, in many cases, the adjuster hasn't even been assigned. In larger employers, there will be one or two or more adjusters assigned to a particular employer. But most of the time, for any given employer, they're not big enough to have their own adjuster at the carrier. And so you don't even know who the adjuster is going to be until it's assigned somewhere and there's a claim number. But yes, the ideal thing is usually at the second or third visit, if there's a significant question about a pre-existing problem, then calling the adjuster, I think, is really useful because it's going to save a lot of problems down the line. Not only how to manage the discharge at the end and whether you do a PR2 or PR4, but it's also what's going to go on with the billing. Because sometimes what will happen is, we think it's a new injury, we're sending off billings, not a month or two or three later, our AR people are getting letters back saying, well, this was an old claim or this was something else. So when there's a significant question about pre-existing problem, at some point, tracking down, and you don't need to make the call yourself, have somebody call for you, but just ask if you can get a copy of the PR4, or in some cases, you'll need to talk to the adjuster yourself. So good point, Amanda. I think talking to the adjuster when there's a significant question about pre-existing problems is a very good idea. Any other questions on this one? Let's move on. So really concluding thoughts, and this is pretty much what we were talking about for the last couple of minutes. So let me stop recording.